Clinical decision aids in the evaluation and management of syncope. Syncope, characterized by a transient loss of consciousness and postural tone due to a temporary reduction in cerebral blood flow, is a common medical presentation marked by its rapid onset, brief duration, and spontaneous complete recovery. Accounts for 0.8 to 3% of ED presentations annually. Despite its frequency, establishing a definitive diagnosis for the underlying cause of syncope can be challenging, with a considerable proportion of patients remaining without a clear etiology even after initial medical evaluation. This diagnostic uncertainty often leads to extensive testing and increased healthcare resource utilization. To aid clinicians in navigating the complexities of syncope management, several clinical decision aids have been developed. These tools aim to assist in risk stratification, improve diagnostic accuracy, and potentially limit unnecessary investigations and hospital admissions. The second overview of clinical decision aids for syncope. Commonly used decision aids include the San Francisco Syncope Rule, SFSR, the Canadian Syncope Risk Score, CSRS, the ROSE, Risk Stratification of Syncope in the Emergency Department Rule, the OESIL Risk Score, the EGSYS Evaluation of Guidelines in Syncope Study Score, and the FAINT FAIN Algorithm Score. San Francisco Syncope Rule, SFSR. The San Francisco Syncope Rule was developed to predict the risk of short-term, 7 to 30 days, serious outcomes in adult patients presenting with syncope or near syncope who have returned to their baseline neurological status. The rule incorporates 5 key criteria, easily remembered by the mnemonic CHESS: congestive heart failure history, hematocrit less than 30%, abnormal electrocardiogram ECG, history of shortness of breath, and systolic blood pressure less than 90 millimeters of mercury at triage. The presence of any of these criteria in a patient is considered a positive rule, indicating a higher risk for a serious outcome, which includes death, myocardial infarction, arrhythmia, pulmonary embolism, stroke, subarachnoid hemorrhage, significant hemorrhage, or any condition causing a return emergency department visit and hospitalization. The SFSR is designed to utilize readily available clinical information and basic laboratory results, making it potentially straightforward to implement in the emergency department setting. Initial studies reported a high sensitivity, 98%, suggesting it was effective at identifying patients who would experience serious outcomes. However, subsequent external validation studies have shown variable specificity, around 56%, and in some cases, lower sensitivity, as low as 74%. A meta-analysis of validation studies reported a sensitivity of 87% and a specificity of 52%. This discrepancy in performance across different studies underscores the importance of external validation and suggests that the initial accuracy of a decision rule might be overestimated in the derivation cohort. The variability in sensitivity also implies that the SFSR might miss a non-negligible proportion of patients who will experience serious adverse events, while the moderate specificity could lead to unnecessary hospitalizations. Canadian Syncope Risk Score, CSRS. The Canadian Syncope Risk Score is designed to predict the 30-day risk of serious adverse events in adult patients greater than or equal to 16 years old, presenting to the emergency department with syncope within 24 hours of the event. It is not intended for use in patients with prolonged loss of consciousness greater than 5 minutes, altered mental status, witnessed seizure, major trauma, intoxication, language barriers, or head trauma causing loss of consciousness. The CSRS incorporates 9 predictors derived from clinical evaluation, investigations, and the emergency department diagnosis. These predictors are assigned points, contributing to a total risk score. I list out the full score below, although the summarized table you see on this slide contains a simpler version. which is also often quoted, the full score listed verbally here. Predisposition to vasovagal symptoms, -1 point. History of heart disease, +1 point. Any systolic blood pressure, 90 or 60, 180 millimeters of mercury, +2 points. Elevated troponin level, +2 points. Abnormal QRS axis, less than -30 degrees or greater than 100 degrees, +1 point. QRS duration, greater than 130 milliseconds, +1 point. Corrected QT interval, greater than 480 milliseconds, +2 points. Emergency department diagnosis of vasovagal syncope, -2 points. Emergency department diagnosis of cardiac syncope, +2 points. Based on the total score, patients are categorized into 5 risk levels: very low, less than or equal to -2, low -1 to 0, medium 1 to 3, high 4 to 5, and very high, greater than or equal to 6, with increasing probabilities of experiencing a serious adverse event within 30 days. The CSRS has been externally validated in multiple Canadian emergency departments and internationally, demonstrating high sensitivity, around 97 to 99%, for identifying patients at low risk of serious outcomes. The CSRS incorporates a broader range of factors, including cardiac biomarkers and the physician's clinical impression, potentially offering a more comprehensive risk assessment. However, the reliance on the emergency department physician's diagnosis introduces a degree of subjectivity. While the strong validation data supports its use in identifying low-risk patients who can likely be safely discharged, an external validation in Italy suggested that the CSRS was no better than physician gestalt in predicting outcomes. CROSE, risk stratification of syncope in the emergency department. The rule includes 7 key criteria: brain natriuretic peptide, BNP, level greater than or equal to 300 picograms per milliliter. Original Rose criteria discusses dyspnea before or after syncope instead of BNP. Revised includes BNP and is more accurate. Bradycardia, less than or equal to 50 beats per minute in the emergency department or pre-hospital setting, or tachycardia, rectal examination showing fecal occult blood if gastrointestinal bleed is suspected. Some variants mention systolic blood pressure less than 90 instead. Anemia, hemoglobin less than or equal to 90 grams per litre. Some variants mention only hematocrit less than 30%. Chest pain associated with syncope. Some variants mention ACS symptoms. Abnormal ECG. Some variants specify Q waves in ECG, and oxygen saturation less than or equal to 94% on room air. The presence of any of these risk factors suggests a higher risk, and admission is generally recommended. Validation studies have shown good sensitivity, 87.2%, and a high negative predictive value, 98.5%, for identifying high-risk patients. The Rose Rule's inclusion of BNP, a marker of cardiac stress, potentially enhances its ability to identify cardiac causes of syncope. The high negative predictive value suggests that patients without any of these risk factors are unlikely to experience serious adverse events within 1 month, potentially allowing for safe discharge. OESIL Risk Score. The OESIL Risk Score is designed to predict all-cause mortality at 12 months in patients presenting with syncope. The score incorporates 4 criteria: age greater than 65 years, 1 point; history of cardiovascular disease, 1 point; syncope without prodrome, 1 point; abnormal ECG, 1 point. A total score of 0 or 1 is considered low risk. Validation studies have reported varying sensitivity, 88 to 97%, and specificity, 11 to 73%. The OESIL score focuses on long-term mortality and includes factors particularly relevant to older patients. However, the wide range in specificity across validation studies suggests that its ability to accurately identify low-risk patients can vary. EGSYS, Evaluation of Guidelines in Syncope Study. Score. The EGSYS score aims to predict the likelihood that syncope is of cardiac origin. A patient is considered low risk, suitable for discharge, if all of the following are absent: abnormal ECG, any of the following; Ischemic changes, conduction abnormalities, e.g. AV block, bundle branch block, arrhythmias, e.g. atrial fibrillation, supraventricular tachycardia, ventricular tachycardia, significant QT prolongation, pacemaker malfunction, history of cardiovascular disease, e.g. CAD, CHF, cardiomyopathy, valvular disease. Symptoms suggestive of cardiac syncope, syncope during exertion or while supine, palpitations preceding syncope, no prodrome, sudden loss of consciousness without warning, positive cardiac biomarkers, e.g. troponin elevation, persistent hypertension, systolic blood pressure less than 90 millimeters of mercury after syncope. The EGSYS rule is best applied to adult patients greater than or equal to 18 years presenting with syncope or near syncope of unclear cause. Low to intermediate risk patients where cardiac syncope needs to be ruled out. Settings with limited resources where advanced testing like BNP or echocardiography is not readily available. Strengths: simple, ECG based and requires no lab tests except troponin in some cases. High specificity, approximately 95% for ruling out serious cardiac causes. Limitations: lower sensitivity than CSRS or ROSE may miss some cardiac cases. Less validated in older adults greater than 75 years or those with multiple comorbidities. FAINT, faint algorithm. Score: the FAINT score was developed for risk stratification of syncope specifically in older adults. It includes frequency, age, injuries, number of episodes, and trauma. From 5 variables, all need to be negative to consider the patient low risk. It relies on just clinical features and ECG and no lab results. Cornerstone 3 components to be applied to every patient that presents with syncope: a thorough history and physical examination along with a 12-lead electrocardiogram ECG. These 3 form the cornerstone of the initial evaluation and can often provide crucial clues to the underlying etiology and risk. The ACP clinical policy on syncope designates these as the only level A recommendations for the evaluation of syncope. History and physical examination can establish the diagnosis in a significant percentage of cases. The ECG is invaluable for identifying potential and specific cardiac causes of syncope, such as abnormal heart rhythms. Further laboratory testing and imaging are ordered and targeted based upon the findings from the history, physical examination, and ECG. When to use which decision aid and when we should not use them. Clinical decision aids for syncope are most appropriately used in adult patients presenting to the emergency department with syncope after a thorough initial evaluation, history, physical exam, and ECG when the cause remains unclear. They can also be used to reassure clinicians and assist in shared decision-making when considering safe discharge for low to moderate risk patients. The suggestions below are not medical advice, but is one possible approach. The Canadian Syncope Risk Score, CSRS, may be particularly useful for identifying low-risk patients who can likely be safely discharged due to its high sensitivity for low-risk outcomes. The ROSE rule might be considered in patients with a higher suspicion for cardiac etiology given the inclusion of BNP in its criteria. Clinical decision aids should generally not be used in patients with a clear diagnosis identified during the initial evaluation or in patients with obvious high-risk features that warrant immediate hospital admission regardless of the risk score. These tools may also not be directly applicable in cases of prolonged loss of consciousness, altered mental status, obvious witnessed seizure, major trauma, intoxication, or language barriers. Furthermore, strong clinical judgment suggesting a high risk should always override a low score on a decision aid.